The title I chose, Childhood Lupus, Challenges in Clinical Practice. Already Dr. Lujain highlighted part of the challenges in the treatment. I'm sure you have more cases than I will show you, but at least the difference, I don't know the right answer for my patient. So we'll see. I will go through brief background, then I will highlight the clinical challenges in the practice using real cases encountered in my practice. I have nothing to disclose. As we know, lupus is a highly complex autoimmune disease with the great heterogeneity between patients, causing anything from mild disease to a life-threatening condition, and with relapsing unpredicted disease course. And you can see any organ can be affected with different or spectrum of clinical manifestation. In my view, lupus should be considered as a construct because it includes more than one entity. All the time we use SLE, but I think we have to choose or to use childhood lupus because as pediatric rheumatologists, we are seeing a spectrum more than what other colleagues from adult rheumatology use. I made this cartoon, the SLE, which is sporadic, the usual one we are using, but still we are seeing monogenic lupus. We have neonatal lupus, we have cutaneous lupus, again with a wide spectrum of manifestation, and drug-induced lupus. So these entities has heterogeneous phenotype, different pathogenic mechanism. You cannot lump everything in one disease or term. Now, we have some problem with the definition. If we choose monogenic lupus, we have difficult to define the disease. As Dr. Najla showed many pathways, and there is new coming indicating the causes of monogenic lupus. So we have poor definition for this entity, and these cases, most of the time, they have blurred boundaries with inborn error of immunity. Not only that, we know these diseases or entities has multi-system involvement, and this led us to consult other services. Yes, it's good to have multidisciplinary service or consultation, but sometimes this had negative impact because they are seeing their care from different angle, which is maybe you don't accept. So in my view, many consultations create a lot of difficulties and challenges as well. Now, Dr. Lujain mentioned the treat to target. We know SLE has multi-organs, difficult. Which organ you will target? Which are you targeting? Nephritis, skin, CNS, hematology, different comparing to, for instance, juvenile arthritis. And for sure, we have limited treatment option comparing with GIA. We have long list of biologic. In lupus, maybe we have only one approved medication. Still, we are using others as off-label. Now, with the advanced in molecular genetics, we have many discovery, but there is therapeutic approval takes longer time to get the approval and to use it in real practice. We heard a lot about the disease severity and definition of remission, and even they are using low disease activity, and still they try to dissect it and choose other terms, low disease activity, clinical, off treatment. So we have poor definition of disease activity status, and it's difficult to apply it in real practice. We have special consideration in childhood lupus because of the age comparing the adult. We have long period of disease comparing to the adult. We have pre, we have peri, and pubertal disease activity, and maybe the clinical manifestation is different, and the way of treat patient also different. We have also growth and development. We have to consider that, and Dr. Jane will tell us something interesting about the growth and treatment of growth in lupus patient tomorrow. And again, the pubertal status and the stage of adolescent and self-management, capacity, medication adherence, and so on. Now we need to consider the challenges of practice. We need to consider diagnosis, treatment, monitoring, and outcome. What I will do, I will just illustrate using cases, hoping to cover these areas. I will start with the first case. This is an 11-month-old girl. She is product of neonatal, normal spontaneous vaginal delivery. She developed petechial rash with thrombocytosis anemia. She had high liver enzyme. And one of the workup showed high ANA and anti-Rho or SSA positivity. That was significantly high. So I can read your mind. You will think about neonatal lupus, which is proper differential diagnosis. That child has persistent thrombocytopenia and anemia requiring transfusion twice, and she had Combs positive. That was done in outside of our hospital. I'm not sure was the Combs test before or after the transfusion. She required IVIG. Now start thinking maybe this is not neonatal lupus. All workup, including infectious workup, negative, and the autoimmune hepatitis also was negative. She had normal C3, C4, and one of the workup showed congenital hypothyroidism on treatment. Because she has persistent high liver enzyme and requiring a lot of investigation, they also did liver biopsy, and it showed portal inflammatory cell non-specific, and also they did gene and West test, and it was inconclusive. However, it was heterozygous for epidermolysis bullosa, which is maybe not related to that. So any doubt about the diagnosis of neonatal lupus at this stage? Okay. Just to remind you about neonatal lupus, I know you know it better than me. The major manifestations are cardiac, cutaneous cytopenia, the high liver enzyme, maybe up to 20% of those cases. And usually, these can be isolated or it can be part of other manifestation, and the spectrum can be mild transaminitis to the extent of cholestatic hepatitis, and rarely present with acute liver failure. And the pathology, if somebody did biopsy, non-specific, it can resemble idiopathic neonatal giant cell hepatitis like that patient. Now, most of these manifestations, as you know, except cardiac, disappeared spontaneously after clearance of maternal antibodies. We agreed. Now, means that neonatal lupus is autoimmune disease in which passive transfer of maternal autoantibodies to the fetus resulting in the fetal manifestation or neonatal manifestation. Means mother should be seropositive ANA for SSA, SSP. We agreed. Okay. Now, 40 up to 60% of mothers had, typically they are healthy, they don't have any manifestation. And maybe those mothers developed lupus within 3 years of follow-up. So back to our patient, mother is healthy. That was the first baby for her, and no medical illness during pregnancy, and she is ANA negative. And also anti-Rho is negative. No history. The father is also healthy, but there is one aunt had known case of SLE. So could neonatal lupus occur in seronegative mother? What do you think? Yes or no? It was persistently high for a long time. The child has repeated, and we have no doubt about ANA positivity in the child. The mother repeated twice, and it was negative. Okay, let us try to answer the question, could neonatal lupus occur in negative mother? This is report in Lancet journal, which is well-known journal, reported by well-known figure, Alberto Martini and Marco Gatorno, and they reported a newborn girl, healthy mother, diffuse vasculitis, rash, hepatosplenomegaly with high liver function test, and child has ANA positive and anti-Rho positive, and she had normal AKG, and mother was negative for ANA and ENA. So maybe this is the case similar to that patient. Interestingly, they did more workup, and that child has lysinuric protein intolerance confirmed by immunoassay and genetic testing. So that child is different from our child. And she had persistent cytopenia requiring DMARD treatment. In my opinion, that was not neonatal lupus because there is a cause explain the high liver enzyme and ANA positivity, and there are case reports showed that protein deficiency causing monogenic lupus. So I didn't think we have neonatal lupus with negative mother or seronegative mother. I don't know the answer. So this is one of the clinical challenges. So the second case is an 11-year-old girl. Her symptoms started at age of 16 months, diagnosed as lupus at age of 4 years. Maybe this case, I share it with many of you in other presentation. Anyway, she had diffuse alopecia, multiple oral ulcers, pancytopenia, comes positive, ANA, double strand, everything positive, and the gene confirmed pathogenic homozygous TALDO1 variant and betaine variant, which is one of the maybe gene causing lupus. And she received the usual treatment for monogenic lupus, at least in our practice. Now, that case was reported a couple of years. And just to remind you about betaine variant play a role in B-cell hyperactivity leading to the onset of lupus, and TALDO-lase variant may cause autoimmune, mainly endocrinopathy like hypothyroidism. Now, the question may be related or not related to this patient. Is childhood lupus patient more likely to develop malignancy? Is there a link between MMF and malignancy? Okay. The data is inconsistent. We don't know exactly, but there is increased cancer risk in childhood lupus versus general population. And using MMF in patient, probably it's more, but we have to remember most of these data came from organ transplant population because they are using higher dose. So we are not sure about the lupus patient of using MMF. Now, does our patient have a higher risk of developing malignancy? I will remind you about betaine is a tumor suppressor gene. So if there is a deficient or variant, this gene has oncogenic function and has been linked to betaine hamartoma tumor syndrome. So there is some risk in those patients. Now, monitoring the disease activity and maintaining her on immunosuppressive drug present a bit challenge because she has risk, and also you are using immunosuppressive medications. So we are not sure, are we adding more risk for that patient? Because we are aware about that, we screened her, and thyroid ultrasound showed hypoechoic lesion with multiple lymph nodes. So still there is a suspicious. We tried to biopsy it, but the radiologist said it's tiny, we couldn't biopsy that lesion. So we have to just monitor. The abdominal ultrasound showed hepatosplenomegaly, but no lesions. The tumor markers showed high alpha-fetoprotein. Still we are following that patient. and we have to wean the medication and monitoring the disease flare. So we are not sure what we will do with that case. Still difficult to counsel the mother or parents with the risk of malignancy, knowing the gene mutation and using the immunosuppressive. So the third case, just remind you about nephritis is a common major organ involvement in lupus, childhood comparing to adult. It's more frequent and severe in childhood comparing to adult as well. And typically they present with proteinuria, hematuria, hypertension, and renal impairment. Typically lupus nephritis confirmed by the presence of full house glomerular immune deposit. So to say nephritis, probably you need to see this type of histopathology. And we will hear from Dr. Turki more details about the renal pathology. Now, this is a case, is 5-year-old girl referred to our colleague from nephrology because high serum creatinine proteinuria. She had feature of attention deficit disorder, mild constitutional symptoms, but no clinical feature suggestive of lupus, nothing. And she found to have nephrotic range proteinuria and very low serum albumin. She had only ANA positive. Other autoantibodies were negative, including double-strand DNA, and borderline low C3 normalized shortly. And the renal biopsy showed proliferative glomerulonephritis consistent with class 3, and the gene was negative. Now, do you consider diagnosed lupus in this patient based on the renal biopsy and ANA? Of course, if you are using SLIC criteria, you have to call it lupus. And this is what they call stand-alone renal SLIC criteria. And this is one of the challenge we are facing, referral from pediatric nephrology. Now, is stand-alone renal SLIC criteria enough for diagnosis of childhood lupus? Are they different, those patients different from the usual cases? And when Dr. Abdelaziz is with us, we try to answer that by this small study. And we compare 6 patients fulfilled the stand-alone renal SLIC criteria with full house glomerular immune deposit nephritis. And you can see the blue column showed these cases. And if you compare it with other SLE patients without biopsy-proof nephritis or with biopsy-proof nephritis, they are different in terms of the ANA titer, it's lower than the other cases, and also the other autoantibodies, typically they have negative, and even the complement were lower, normal comparing to the usual lupus patient. Not only that, the serum creatinine, usually they have higher, and even the chronicity, by biopsy, they have advanced more chronicity than the usual SLE. Regarding the treatment, probably they are not responding as expected. And the interesting thing, some of them, they showed, none of those patients progressed and developed more clinical manifestation. So still, it's difficult, and I'm sure most of you received consultation from pediatric nephrology, and this is SLE, you have to deal with that, although we don't have. And I know Dr. Sumbul is struggling with these cases all the time. He's talking to the nephrologist, but still, we have to accept based on the criteria. So stand-alone renal SLIC criteria represent diagnostic dilemma for both rheumatologists and nephrologists. The question is it possible to encounter lupus patients with non-lupus nephritis? Can they present with other histopathology, not the usual? As I mentioned, it's typically immune complex mediated disease, and you will see full house nephritis. Now, renal biopsy from lupus patient rarely shows changes that are pathogenetically and morphologically unrelated to lupus. However, there are cases you may see focal segmental glomerulonephritis not related to lupus, but with other clinical manifestation with autoantibodies, probably you should accept the diagnosis of lupus and treat them as lupus. The last case I will present, 12-year-old boy presented with a 3 years history of peripheral arthritis, knees and wrist, work up at the referral hospital, and he had high inflammatory markers, positive ANA double strand and SSA, SSB. He had low complement. After 1 year follow-up, presented with back pain, and as you can see, the MRI X-ray showed sacroiliitis, which is unusual for SLE patient to have sacroiliitis. Now, 6 months later, he had chest pain, vasculitic rash in the palms, soles, and malar rash. And what was next? He had leukopenia, proteinuria, and ANA persistently high, double strand, and low complement, pericardial effusion, and renal biopsy confirmed class 4 nephritis. Now, what is the diagnosis? Could this be lupus with enthesitis? It's very unusual to see enthesitis, sacroiliitis in SLE patient. Could this be overlap syndrome, what they call it, lupus? Personally, I don't think this is proper term to use. Maybe this is old name and before the genetic testing. This patient, we didn't do any genetic because already transferred to adult, but this is the only patient I have, and I'm sure if you see cases of sacroiliitis, enthesitis in lupus, childhood lupus. As I said, the arthritis is commonly the initial presentation like hematological manifestation, and it's very rare to have axial involvement in lupus patient. So the concept of overlap these days remains most unsatisfactory. We have to figure out what is the cause using the overlap or mixed connective tissue disease, not the real mixed connective tissue. You need to have some genetic test to figure out. So in summary, lupus remains a challenging disease, both diagnostically and in terms of long-term management. It remains the great mimics for many diseases, entities. The clinical pathway strategy is difficult to implement for lupus patients. If you compare it with straightforward diseases like infection, it's very hard to use the clinical pathway. The definition of lupus has been refined over the past 30 years, but in the sense it has changed a little. The concept of overlap remains most unsatisfactory. With that, I will stop here and thank you.
Any question for Dr. Mayouf?
Thanks, Suleiman, sharing this difficulty, which really I think most of us have it the same thing. And may add to this thing actually is losing of the efficacy of the treatment in good number of the patients, especially with those having monogenic lupus or genetically inherited. Sometimes really you think you are doing great, starting certain medication, doing fine in the first few months, then everything is gone. So no more, and we don't have any more, as you said, really enough other alternative treatment which you already tried. I think this is one of our biggest challenge as well. Sometimes really, as you mentioned, especially for those having, apart from the lupus, they have other organ involvement from CNS, musculoskeletal, and others. And I don't know, maybe really our patient, those type of group of patients, maybe, I don't know, maybe it's very good chance for those, I mean, having more basic research targeting a new target therapy or new modality of therapy. Hopefully we'll have something in the future. I don't know, what do you think about these special cases, Suleiman?
I told you the difference, I don't know the answer. All these cases, I don't know the answer.
يعطيك العافية دكتور سليمان. It's an interesting case and you really go different multiple challenges and real challenges with the patients. And we saw that it's a heterogeneous. Some challenges with the neonatal or infantile presentation, some with renal manifestations, some with unusual arthritic manifestations. With such heterogeneous disease and the difficulty to have a single biomarker to help in the control of the disease. Do you think it's a time to have a composite biomarker? Like now we have a composite disease activity scores like SRI-4 and BICLA to combine multiple outcome measures. So is there a possibility to have a combined biomarkers to get different biomarkers like lupus panel, like whatever you like to name it, to have multiple pathway that important in disease process who have multiple disease presentation and multiple disease pathogenesis?
Well, personally, maybe I'm not right in my answer, but I don't think the panel or the composite will be the answer. In my practice, I never saw lupus patient mimic to the other lupus patient. All are different. I think there was trial to have auto-inflammatory panel, and now people start to move away from it because it's very many gene beyond that panel. So they stopped doing the auto-inflammatory panel unless you keep updated. So that it's not a panel anymore, and it's not composite anymore. So personally, I didn't think the answer would be there. You have to deal with the patient as individual case. I'm not sure, but the expert here, they can correct me.
Okay, thank you for the presentation, Dr. Suleiman. Quick question about the last patient who have like enthesitis and lupus. I mean, I had a similar patient, and I just felt like, it's very hard to pick up the immunosuppressant for this patient because, TNF inhibitor is very good for enthesitis, but probably not a good idea in a lupus patient. So how did you treat that patient? Well,
I try to choose cases from diagnosis, monitoring, and outcome rather than talk in details about each case. For instance, the neonatal lupus was treated with steroid for a good time. Maybe you agree, disagree, and things improved. Maybe this is the nature of the disease rather than treatment. For that patient already transferred to the adult, I don't know what happened for him, but when he was with us, we treated him with cyclophosphamide before you get rituximab and belimumab.
Thank you, Prof. Suleiman, for sharing with us these challenging cases. Knowing lupus is kind of interferon pathway-mediated disease, do you think having an interferon signature before initiating therapy and comparing like monogenic for non-monogenic lupus might give us some indication about the pathway response to treatment afterwards? Do you think this might be thrown as a research project?
Well, this takes us again to Dr. Buthena. I don't think this test or the facility is available everywhere, but maybe in future, yes. Again, using these markers, it's difficult to now people, they are considering JAK inhibitor, interferon pathway treatment like infliximab, even without doing interferon signature. So it will come, but I'm not sure this will guide the treatment. Maybe in the research level, yes, but in real practice, this is challenging in practice. So this is what we are facing.
Allah يعطيك العافية, Prof. Comment or small comment. And you mentioned one patient with lupus nephritis with ANA positive. And we have today afternoon poster with Dr. Abdulaziz. We have two patients with approved lupus nephritis and ANA negative. So if you call it SLE or SLE-like or something else, I like your comment at the beginning, it's like a spectrum of the disease and it's not like an SLE. Like Dr. Wafaa said, I don't think it's like only interferon-mediated disease. I think there is a lot of different pathways and different patients, and we need to treat each patient individually.
We have 1 minute only for Dr. Abuhaina.
Dr. Sulaiman, just I want your thought on this. Do you think increasing the age group to 18 will catch more of these patients, especially that we know that once they landed to adult, they're not going to do genetic testing and they're just going to treat them prickly?
Yeah, for sure. But as a pediatrician, probably you are not, let us say, aware about many pubertal or adolescents, especially in girls. So I think transferring them to adult maybe is more safer for us.
Thank you so much, Dr. Mayur, for this informative talk. Dr.
يعطيكم العافية جميعا.